I have with me as my co-moderator, Professor of Ophthalmology, Dr. Rohit Saxena, who is also a member ARC North Zone, to add strength to today's show. It's with great joy and happiness I'm starting off my first webinar of the ARC, and I really look forward to reaching out to all of you in the very best way possible what this pandemic is going to allow us in the coming days. We decided to kick-start the sequence of programs with our very popular concept, a video bouquet of cataract surgery in complex cases. We plan to come out with more of these webinars in different subspecialties along with our PG update programs. We would then go on to our day-long CMEs once there is a semblance of safety. Today, we have with us a galaxy of speakers, as I'm sure all of you can visualize. They are experts in their fields who would run you through some of the complex moments in cataract surgery, which often keeps us grappling to find out the best way out with the best solutions. There would be altogether 12 videos, each of 4 minutes duration, interspersed after each with a 4-minute discussion by the moderators and some of the speakers. Active audience participation and discussing the doubts raised would be ensured in the course of the meeting if it is feasible, but definitely we would stay back and clear all your doubts towards the end of the session. So shall we start now?
I think great. All the best.
Our first speaker is Dr. Kumar Doctor. As we all know, he's the director of the Doctor Eye Foundation, is one of the most prolific surgeons of our times, has been the past president IRSI and past member scientific committee, and is also recipient of Best Paper Awards and Best Video Awards. Today, he would be back to us, teaching us through his videos. On to you, Dr. Kumar.
At the onset, I would like to thank Chitra for letting me participate in this symposium. And this is your first symposium after the elections, and I'm the opening batsman. So I'm going to show 2 videos. Can I have my video on, please? So this is a first case of a simple procedure of hydrodissection and another case of meiosis during the phacoemulsification. So the first case is a hydro complication and how we get away with the problem. So as you notice here, my associate has done a CCC slightly smaller in size, about 4.5 millimeter in size, followed by hydrodissection. Please watch now the fluid wave going across, and I'll tell you when it goes. This is the moment you watch it, and that's the fluid wave gone. No decompression happened of the nucleus, and the second fluid wave causes the lenticular pressure to go up, and watch the rip that happens in the continuity of the CCC. Now that's in slow motion, and you can see at about 5:30 position, the CCC has given way. Now the question is, how is the situation? And has this gone equatorial or beyond that and caused a rent in the PC? So you reduce the bottle height as much as possible and then go ahead and do phacoemulsification. You can see a sharp tip, a shining tip, and that's because it's a new tip. And now we are not going to phaco in the direction of the rip at all. What we are doing here is phacoemulsification with the chopper in the left hand and going ahead, occluding the tip, and then going ahead and gently rotating the nucleus. Once the nucleus is rotated, we bring it back to the level of the CCC and then apply the phaco power and make sure that the nucleus is emulsified. There is a flap motility sign which Dr. Rohit Prakash has shown in the American Society, and that had got an award. It means if you notice the flap of the CCC is fluttering in front of your eyes, that has not gone till the equator and beyond. If it has gone beyond the equator, the flap will not motilate. There will be no motility of the flap. The flap will be very taut. If the flap turns inwards, that means it has gone to the PC and the rent has happened. This is a bimanual IA. Preferably remove the subincisional cortex first because that's where the CCC is intact. Go ahead and then remove the rest of the cortex. Only in the area of the flap where it's given way, one has to be a little careful to make sure that you don't hold the flap by mistake because that itself can cause traction on the CCC and pull the zonules. So at this stage, I'm just making sure that all the cortical matter is removed. Once the cortical matter is removed, you'll see the two flaps, and throughout the process, the flap has been motile. It's just flapping up and down, and that means the tear has just reached the equator. It's not gone beyond the equator and not gone to the posterior capsule. If it had gone to the posterior capsule, this will be a taut flap and it will not be motile. In fact, the margins of the flap would be turned in. This is proven by Dr. Rohit Prakash in his presentations many, many times before. So this is complete cortical removal. Now I want to put the lens in the bag. The leading haptic goes in the bag. And the trailing haptic, I don't want to dial this lens because I want to make sure that the area of the tear does not extend beyond that area. So here I try to gently place it behind and into the bag. I'm not sure whether the superior haptic has gone because it's gone, I think, into the sulcus. So now I make the lens horizontal. We all want to put our IOLs horizontally in the bag to prevent dysphotopsia. I re-inject viscoelastic, make sure it goes a little deeper, and now I do a bimanual technique to make sure that the haptic, that's the superior haptic, is in the bag or not. So I made the lens horizontal. Now I'm holding it. Now what I'm doing is I've brought the haptic into the AC because I'm not sure. So this way I brought the lens back, the haptic back into the anterior chamber, and now with the bimanual technique. So I've taken the Sinskey hook in my left hand, going ahead and holding the haptic gently, depressing the optic at the same time, and making sure that it just goes below the margin of the CCC at that level. So this makes sure that your IOL is in the bag in spite of you leaving. Now I'm going ahead and checking where has it gone till. So you can notice that you can see the tear in the CCC, but it's only till the equator. Behind the posterior capsule is fine and everything has gone well. So even if you have a tear in your CCC, look for the flap motility sign and you can still go ahead and do a safe phacoemulsification without any issue. Gently, of course, at this stage, just remove the viscoelastic from in front of the IOL and behind the IOL, and you can see that the flaps come closer and everything has gone well. So even if you have, this was because of the high pressure, the high lenticular pressure, such a complication can happen. I've just shown a way how one can do safe phacoemulsification and get away without any complication at all. Of course, if the flap motility sign was not there, the things would be very different. So this is the first case that I'm showing.
Okay, that was a
Thank
wonderful video. That was a wonderful video and a lot of learning for all of us. And I'm heard, and I'm sure all of us know he has shown us all the tenets and all the principles which have to be followed. But I have a question for you, Dr. Kumar. Are you sure there was no capsule tag when you say felt that extension happening?
No.
Was your capsule Rhexis intact at that point?
Yes. Rhexis was absolutely intact. It was round. So what has actually happened, it was a 4.5 millimeter Rhexis. And if you tend to put a heavier viscoelastic in the center, and when we do a hydro procedure and you don't decompress the nucleus, there's no breaking of the equatorial cortical adhesions. Now that builds up the lenticular pressure so much that the second fluid wave actually made the whole anterior capsule tear across and all the fluid came out. So there was no tear before we did that procedure.
There could have been one more way of dealing with this moment. Probably sometimes, you could even change the location of your incision. Like
yes.
if it's temporarily, then this extension would come subincisionally, and you would find that the fluid wave would not go behind the Rhexis extension, would not go up to the posterior capsule. That's one way of dealing. When would you decide that you are not going to do a Phaco, you're going to convert to SICS? Have you ever been caught in a moment when you've had a Rhexis extension like that?
Yes, so if we, as I mentioned in my talks, if what you said is correct, but here I'm sitting superiorly and I'm operating superiorly, so the tear was inferiorly, so I made sure that my phaco tip throughout the procedure was not in the direction of the tear and it was little away from there. That's step one precaution I took. As far as what you said is, yes, this can happen, but you have to look at the motility sign. So if you feel that the flap motility is absent, it is taut, okay, it's completely taut and the flap refused to move. If the tear extends beyond the equator into the PC and almost towards the center, sometimes the flap margins turn in. And that will say that, yes, now whole scenario will change and your whole approach will change. It all depends on whether the nucleus is sinking. If it sinks, then you do a pass plana. If it doesn't sink, it all depends on what stage this happens and how the nucleus behaves.
Dr. Soosan, I find Kumar is literally swearing on the slap motility sign every now and then. Do you think that you could have an inverted fluttering flap and you would be so confident and continue your Phaco being sure that it would not extend at all? Or do you have any other question regarding Kumar's case, or do you think he has justified himself quite well?
I think he's done a pretty good job there, managed it well. Flap motility sign is something that I would definitely pay a lot of attention to. It has been shown to lead you in the right direction, when you're wondering whether the tear has actually stopped short of the equator or whether it's gone around. And I think it is definitely a wise decision to pay attention to that sign and, continue your surgery depending on that.
Does anybody else have anything to add at this point? Yes, Harshul?
I think that was a wonderful demonstration, Dr. Kumar, as if how to proceed with Phaco in case you have an anti-capsule tear. And I think the key in those cases is, of course, to maintain a closed chamber, as you also showed. So whenever you are taking out your Phaco probe, you should put OVD first from the side port, may let the chamber be maintained, and then you come out. The same way, once you finish the irrigation aspiration of the cortical matter, if you need to change the hands, again you go and put OVD. So it can't be emphasized more that it's very crucial to have the deep anterior chamber, because if there is any anterior chamber collapse, that can extend the tear then and there into the posterior capsule. That's
I think we are well within time, Dr. Rohit.
Yeah.
Can we take
One
one more
question was
Okay.
there.
Okay.
How would you change your parameters
No,
for this particular case as compared to a routine Phaco that you would have? So noticing that there is a tear in the anterior capsule.
So what I would do is reduce bottle height, and that's the most important thing. And as mentioned by Harshul, is to continuously make sure that you fill the chamber well. Once you reduce the bottle height, with new machines, I'm really not worried about the rest of the fluidics. My vacuum remains 500. I don't think I'll reduce my vacuum, because if the occlusion is not there, the vacuum is really not going to act. And as far as the flow rate is concerned, I don't think that's a bigger issue at all. So main important thing is the bottle height. If I reduce the bottle height, I'll see if there is any surge happening in this thing. If the surge happens, I'll play with my flow rate. If there's no surge, and that's all I'm going to do is just reduce the bottle height.
I think,
can I just add a comment here?
Yes.
There are two things. One question which Dr. Chitra had posed was, would you like to convert to a non-Phaco technique?
Yeah.
Now, there is one situation where I feel one should seriously think about converting to a manual SICS technique, and that is if you're dealing with associated comorbidities. When you have a very hard nucleus, you have a shallow anterior chamber, and the endothelial status is not good. So that is the situation I'll seriously think about not going ahead with Phaco and do a non-Phaco technique. Second point, Kumar, is it possible to first release the entire lens in the anterior chamber and in a very guarded and controlled manner, tuck the haptics under the Rhexis margin so that you don't really have to rotate the lens?
It's possible, but as you notice, I did not rotate it. I put the inferior haptic straight into the bag and then rotated anti-clockwise instead of clockwise. Normally we rotate the lens clockwise. Here I rotated it anti-clockwise and made sure that the haptic which has gone into the bag is made horizontal. And that's the reason why the trailing haptic went straight into the bag after I dialed it and then bring in the anterior chamber. So I did not rotate this lens clockwise, what we normally do in our procedure.
Very well managed.
So very well. Shall we go on to your Kumar's second video?
Thank
the
you.
one on intraop meiosis.
Yes.
One question before, there was a question that can you put in a premium IOL if there is a tear?
Easily.
A toric?
Yes.
Not toric.
So no, it's controversial. No, but I would still go ahead and put a toric. Only thing different that I feel will happen is, see here the capsular phimosis is not going to be a fear. PCO and movement of the lens may be there, yes, but I will still put a toric in such cases.
I wouldn't though. So what's happening? We go on to the next.
So let's go on to the next.
Mr. Puneet.
Can we play the second video, please? Thank you. So this was again a 65-year-old male patient on prostate medication. Came to me for surgery for cataract. You can see it's not a dense cataract. I put a dispersive viscoelastic on the pupil. The size of the pupil is 5.25 millimeter. Being a good surgeon, I thought I'll get away with any problem. Sometimes God is not always with you. That's a take-home message here. And I'm going ahead and doing my CCC. So the CCC will be about 5 millimeters in size. And if you have a new tip, which is a sharp tip and a grade 0.5 cataract, a soft cataract, the tendency here is that whenever you try to go ahead and do phaco and occlude and try to chop and bring the nucleus into the anterior chamber, the sharp tip itself, the vacuum itself is good enough to break the occlusion and the nucleus drops back. So now you have a 5.25 millimeter pupil and a nice round CCC. Now watch what happens. This is a straightforward case, a soft cataract, a small pupil, and now see what happens. I'm going ahead and doing my phacoemulsification. It's becoming a plate because it's a soft cataract, okay? And you can see the side port, you can see the main incision, the pupil is trying to come back. So you saw that I held the iris once. Let's watch the same thing in slow motion. And now I'm again going to hold the iris by mistake. That's in slow motion. I'm not applying any phaco energy by mistake. It has been pulled. Now I'm thinking what next to do. Now I'm using my chopper to push the iris away because it's coming in the field of my phacoemulsification. And now what? So I think, okay, I'm still not a bad surgeon. I'm a good surgeon. I'll still get away with any issues. So I come out and at the same time notice your main incision, notice your side port, that the iris is trying to prolapse, okay? That's because, as I said, 65-year-old patient on prostate medication, I'm using a dispersive viscoelastic again, holding on to the pupil, thinking that this size of the pupil for a soft cataract is easy for a safe phacoemulsification. But do not push. 1 point take home message again, do not push your luck, right? You can have problems and do not have any ego. So we have lots of tools at our rescue today's world, and we have lots of things. And now the pupil has again started coming down on me. The straight one has become horizontal. Again, the side port is, the iris is trying to come out. The iris is coming out through the main wound, and the pupil has further come down to about 4.5 millimeter in size. So now the question is what? So we can use hooks. We can use a Suven Bhattacharya ring, or you can use a Malugan ring. Now, very, very important take-home message that in such scenarios, if you want to use any device, make sure that your CCC is not entrapped when you're trying to put a ring. Here I'm trying to put a Malugan ring. As you notice, I put in 2 parts of the loops inside and now the last part. And now my phacoemulsification becomes extremely safe. So I go ahead and do phacoemulsification. At one stage, I feel that my CCC is entrapped with the iris in one of the loops which is there in the Malugan ring. Here I'm going and removing the nucleus. I bring the nucleus to the level of the CCC, apply phaco energy, remove the whole nucleus, and that's fine. So now you'll notice that I'm adjusting the Malugan ring. That is it, that you can see the adjustment now. And I made sure that the CCC margin is away. I remove the Malugan ring after putting the IOL. I have to remove the viscoelastic. But mind you, friends, notice the size of the pupil. It's become 3 millimeters in size. Okay, the pupil is coming out to the main incision. Luckily, I use a cohesive viscoelastic, which is very easy to remove. It just comes out as a blob. There is really nothing much to worry here. And I'm making sure that all the viscoelastic in front of the lens, because the lens compartmentalizes the viscoelastic, is removed. So the viscoelastic in front of the lens and viscoelastic behind the lens, both will be removed, and it comes out as one blob. The iris is placed back into the anterior chamber. The wound is hydrated, and the lens, this is irrigation behind the lens to make sure that there's no viscoelastic at all. So you can see that the pupil has further come down to about 4 millimeters in size. Hydrate the wound, and procedure which actually caused an intraop miosis could be managed quite well because of all the tools that we have to our aid in surgery today. I think that ends my presentation. Thank you very much. And any questions I'm looking for.
Excellent, Kumar.
Thank you, Chitra.
Showed a situation which could happen in any of our hands. Now, the first instance is he was on a femtocataract platform. Although the cause of miosis was not the femtocataract, but we just need to remember.
It was not in a femtocataract. It was a normal case.
Oh, it was not on the femtocataract.
Yeah, because I did my Rhexis with the forceps.
Oh, you did it with the, okay.
So this was a normal 65.
I would want to say that the initial part of the miosis was not because the patient had enlarged prostate. I think it was that first catch of the iris which triggered the problem. And of course, then the other concept added on.
Yes.
Now, as he was doing phaco, all of us realized that he was trying to get to a chase of a fragment and get to impale it and get it forward and take it out. And when it was not happening at one point, he rotated it, tried to get approach to the other end. So essentially, it's very important for us to remember that when you're doing a very soft cataract, the vacuum should be just appropriate. You could retract the iris if the pupil is getting myotic, and you get to hold it. And at that time, the energy should not be high. Because if you are using higher energy, then you're actually emulsifying the soft cataract and you lose occlusion. So anyway, he went about it to the best of his ability. And then he ended up with a bowl kind of a situation, which is something which has happened to all of us. So my question to Kumar is, before you thought of putting a Malugan ring, did you think of doing a hydroprolapse and, getting approached to a pole and getting it out or cartwheeling it out? I mean, you did it beautifully, the way you
Yeah,
showed the
Chitra, you're right. But
sequence
the
of
point
events.
here is my CCC is not very big. Okay. So my CCC, if I want to do a hydroprolapse and try to bring it out, I need a little larger CCC. Secondly, the pupil was a little small. Any procedure that you try to bring the nucleus out is going to rub your sphincter and the pupil will still further come down. So I prefer that we try to avoid this situation like this, because if anything like this you bring in, and I'm never not very comfortable of doing phacoemulsification in the anterior chamber. Only thing here, what I feel is that even if I reduce my vacuum, okay, even if my vacuum was 60 and not 500 or not 300, believe me, it's the sharp tip. It was a brand new tip and a soft cataract. So moment you have a vacuum or whatever it is, it holds, the sharp tip goes through the nucleus, it sucks the nucleus out, and the rest of the nucleus falls back into the back, and the back forms again. So the biggest fear in a small pupil, in a 65-year-old male patient with prostate treatment with a floppy iris, is the pupil coming down on you and it becoming a plate. Then the plate will become extremely more difficult to handle. Then many times we have to make sure that the bevel down we go in, hold the nucleus. Again, the fear is sharp tip. It can go through and rip your posterior capsule. So this is just the thought that I thought that this was the easier way of managing.
There's one more question I have for you before I would want Dr. Shreyas to take over. Would you have a set plan that when you would use a ring or when you would use hoops? Do
So
you have?
that's a good question, ma'am. That the thought process here is whether whatever you use. Point here is if I knew this patient is already got this, had a prostate, it would have been wise that I put the ring on step one. So before I do my CCC, then this whole thing would have been avoided. So bottom line is, however good we are, sometimes we can face this. It all depends on economics. Hooks cost 500 rupees, no financial interest. The Suven Bhattacharya ring around 2,500 and the Malugan ring around 7,500. So it all depends on what access do you have at that moment. Only disadvantage with the hooks is you need to make 4 ports and you need to remove it. And it's not anatomically nice when it comes down because you'll have a few sphincter tears.
Not necessary. Probably each of us do what suits us best and which
Yes.
technology we are comfortable with. But I think there's one instant to my mind I would use hooks is if the anterior chamber is very shallow, then I would think about pushing in a Malugan's ring, and I would prefer to use a hook. Dr. Shreyash, can you take over and tell your thoughts on this? You're on mute.
Yeah, I've unmuted myself. Sorry. No, with regard to rings or hooks, I agree with sir that each of our preference and what we are comfortable with, and I think both of them work quite well in these situations. And like he said, I mean, the way the case started off with the pupil being 5.5, 6 millimeters, probably none of us would have thought of putting in hooks or rings. Maybe just a couple of points I'd like to emphasize here is the fact that what challenge most of us might face when we are doing a phaco in a soft cataract, which is basically what the challenge was in this case. I think in a soft cataract, the nucleus is a very precious commodity, and we have to really treat it with care. So the settings which I usually prefer is having a very high vacuum, very low energy. I try to occlude deep into the nucleus with just the high vacuum, and then do my direct chop, and then rotate it and do one more chop before I evacuate any pieces. So once you have 4 pieces, it becomes extremely easy. Probably the other thing where you hardly need case is also maybe doing a hydrodelineation along with a hydrodissection. That also helps because the nucleus comes out very easily. You're able to, even if your chop is not complete, you're able to tumble out a portion of the nucleus, which then makes the nucleus evacuation easy. And then it's just epinuclear sheath removal. So maybe just a couple of things which will help in any soft cataract, and probably would have helped in this case.
Only one question here is that some doctors actually autoclave tips like that. Old tip, brand new tip. If it's a very hard cataract, use a brand new tip. If it's a very soft cataract, use an old tip. And this might also help your surgical technique. So this is what I think, that even if you use an old tip, this would not have happened. The nucleus would not have got sucked out in some portions and forming a plate. So that's one more.
I'd like to make a point here, especially for any beginner surgeons who are watching. One is that if you have a small pupil also, it's always possible to go underneath the pupil and make your rhexis actually larger than the pupil size. So don't get constrained by the pupil size absolutely. You can actually take it around so that it goes underneath and you get a larger rhexis size than the pupil. And then I like doing the procedure in soft cataracts where often, like you said, Dr. Kumar, that you get a purchase of the soft cataract and then suddenly the vacuum just takes it off and you find that you have lost that vacuum completely, that hole completely. In that case, what you can do is you can actually rotate it a bit and make it a bowl actually. And like Dr. Chitra said, you can try to hydroprolapse it out. And that does happen even with a 5.5 millimeter pupil. Though sometimes what might happen is it comes out of the rhexis and it gets constrained by the iris, the rim of the pupil. In which case also that's also perfectly fine enough. You just need it out of the rhexis and then you can just emulsify it in the back. So that's actually a nice way to deal with these plate kind of situations.
I think I would have to go on to the next speaker
So
because
one or two questions
running.
I just thought I'll ask, which were coming up.
So I think Arup has a question to ask.
I'll just run through one or two. Of course, the malignant ring and the hooks you put under topical only, or is there any other?
Topical.
So do you give any intracameral or?
No. Yes, intracameral xylocard.
So you will add intracameral xylocard before you put the hooks?
Yes. No, it's my whole surgery is under topical, so every step is topical.
Okay. No, before you put the hooks, would you add intracameral or?
I really don't think it's necessary.
Okay.
So we shall go on to our next speaker, Susan. Maybe Rohit, if you feel I have time, you should let me ask questions to the other speakers. I'm not keeping tab of the time.
Okay.
Dr. Susan, very endearing, soft-spoken ophthalmologist she comes across, is in fact a beacon for the Agrawal group of eye hospitals. She's a director and chief of Cornea and Refractive Foundation. She is on the editorial board, believe me, of every coveted, reputed international society one can name of. And she's a genius when it comes to innovations beyond compare, be it for the Indian community or the international ophthalmic community. And she's going to lead us through some of her very innovative surgeries, as is her forte. So on to you, Susan.
Thank you so much, Chitra ma'am, for that very, very sweet introduction. If I can have my video to start playing, this is actually an interesting case that I've taken for the reason that I do a different kind of management for the two different eyes, even though it's the same pathology in both the eyes. So I'm going to show the first eye, the right eye first. This is a patient with microspherophakia, a young lady, 35, around 30, 35 years old. You can see that what I do here in this case is basically a lensectomy. And even though I have access from both sides, one of the problems that you have in this lensectomy is that pieces can fall into the vitreous, and then you have to go behind it to get it out. Now I've done that, and I'm going ahead and doing a glued intraocular lens, and this is one of the managements which is possible. Of course, there are different kinds of managements that can be possible for this situation. Uh, there basically are two or three managements. I'm going to be showing two of them here. So this is one option where you do a lensectomy vitrectomy. And the second option is what interests me, which is a technique that I had described, and I call it as a supracapsular glued IOL. Now, glued IOL, everyone is very familiar with. You actually remove the entire cataract and then you put it in a monocameral eye, which means that the eye a single chamber. Here, instead, what I'm doing is I'm doing a phaco emulsification. Basically, I have done a Rhexis. And of course, Rhexis is a little bit more challenging in a subluxated cataract, but it's generally possible to complete it. This is a patient with zonulopathy, it's not completely subluxated. But since it's likely to be a progressive zonulopathy, there is a chance of a late bag IOL dislocation, CTR dislocation, if you do just a intraocular, in the bag IOL implantation. So I had put capsular hooks to do the phacoemulsification. I've removed those hooks now, and I'm trying to do a PCC here. Now, I started out with the intention of doing it with a forceps, but then I decided that I would go ahead and do a vitrector instead, vitrector assisted PCC. At this point of time, I've got some vitreous coming out of the capsulectomy, posterior capsulectomy. Now, once I realize that, I go in and stain it with IVTA, and I remove that vitreous, that stained vitreous, which is coming into the anterior chamber. Now, once this is done, what I do is I need to push the bag behind. So I put in some cohesive viscoelastic into the space between the iris and the anterior capsule of the bag. And the same is done on the other side. And in both the areas, I make this sclerotomy, which is basically passing in between the iris and the anterior capsule. So now I do a glued intraocular lens technique. But remember that this glued IOL is going to be in front of the anterior capsule, and you have got an entirely intact anterior capsule and the posterior capsule, except of course for the Rhexis and the posterior capsulectomy. Other than that, it's an intact bag. And so what you essentially get is very stable intraocular lens fixation. There is no monocamerality of the eye. There's a very good separation of the eye into an anterior chamber and a posterior chamber, which is sometimes very vital for patients who've got posterior segment pathology, such as a high myop or a patient who's got Marfan's or things like that. You would like to retain as good or as extensive barrier between the anterior chamber and the posterior chamber as possible, in order to prevent pseudophacodontoses and endophthalmodontitis. So at the end, after that, what I do is essentially as done in a glued intraocular lens, which is basically close the flaps and the conjunctiva. That was the first post-op day appearance. In comparison, this is the other eye, the previous eye, the right eye, where I did a lensectomy glued IOL, and you can see that it's basically there's direct communication between the vitreous and the anterior chamber on the sides of the IOL or around the IOL, whereas this is about 2 to 2.5 months post-op of the eye, where I did a supracapsular glued IOL, and you can see that the IOL remains absolutely flat. It's lying against the anterior capsule, so there's no tilt at all, and it's a stable long-term fixation of the IOL that you attain in this way.
So I'm going to ask you a couple of questions, and I'm sorry I would be asking only one person to ask. We are running short of time. So Susan, that was a wonderful case which you showed how the first instant of a nuclear lens dropping which could occur if you do a lensectomy, and why you have done your other procedure. But I see that you had the capsular bag which is quite wrinkled. You did a very good phacoemulsification, and then you've created a opening in the thing and done an anterior vitrectomy there. So my question to you is, after having placed a supracapsular glued IOL, why didn't you remove the capsular bag? It could get contracted and it may not be good for the visual axis acuity.
So, so there are actually different ways that you could do this. The possible problem that can happen with this technique is phimosis in the long term, which is the reason that you can actually put in 4 relaxing cuts on the anterior capsule as well as the posterior capsule. That was actually my intention when I started out with the PCCC, that I could put some relaxing cuts so that it doesn't actually phimose towards the center, but it just instead forms a fibrotic support for the IOL instead. So that was what I was planning to do intraoperatively, but then I had a vitreous prolapse for which I had to do a vitrectomy. On the other hand, to do it in a much more stable and controlled manner, you could do this post-operatively with a YAG laser, and that's definitely a better preference, which means that you do the surgery, come out, leave it exactly as it is, and then do a cruciate cut on both the anterior capsule and the posterior capsule with a YAG, so that it doesn't phimose and come to the center. The other option is to put a capsular tension ring and then do an optic capture of the IOL so that everything lies there and the chance for phimosis is less. And of course, the third option is to do neither the lensectomy, vitrectomy, nor the supracapsular glued IOL, but basically do a bilateral fixation of the capsular bag to the scleral wall. And my preferred technique in that case would be my glued capsular hook technique, which gets rid of sutures completely, and you can just attach it on both sides with this thing. But what I want to say is you don't want to do one-sided fixation of the bag to the scleral wall, because that in the long term, in these progressive cases of zonular dialysis, would lead on to subluxation from the other side as well, and then you would get a late post-operative bag IOL dislocation.
Yes, that was a good answer. Dr. Haripriya, I would like you to just ask one question before we go on to Arup's surgery.
Yeah, so I think it was very well done technique. Congratulations. So it's a good technique. So again, I think the similar question which Dr. Chitra had raised, I was also wondering, what is the issue of capsular bag contraction beyond phimosis? That's the only concern I would have, especially since many of these patients could be children and young adults. So that is the main concern. Even if we do a YAG, lysis of the rim of the anticapsule or the posterior capsule rim, I'm wondering if there could be an issue of capsular bag contraction and which would obscure the visual axis.
Actually, I have a patient with aniridia where I did her as a very small child. I think she was 2 to 3 years old, and then I saw her when she was 7 to 8 years old. I mean, of course, we've got follow-up throughout. And at some point of time, when the bag did start to fibrose, as you would expect in a child, when I first operated, she was about 5 or something, and then we had a 5-year follow-up of about 10. So at that point of time, we did a cruciate capsulotomy. I had done a PCCC for her though in the first instance itself. So the posterior capsule never got, opacified. So she had a clear visual axis. But then we did anterior capsular rim cuts with the YAG laser, and we found that it really gave very good stability. And the other thing also is that, the entire aniridia IOL was supposed supported well, and also she has some fibrosis in the periphery which could get rid of those defects which go between the iris and between the aniridia IOL and the stump of the iris, because in aniridia you don't have the entire iris. So even if you put an aniridia IOL, you might sometimes have some clear areas between the margins of the aniridia IOL and the iris stump through which you can get glare and all. So this actually helped in occluding that part of the exposed visual axis, and I would say prevented some amount of glare in that way as well.
So very well said. So we go on to our third speaker, Dr. Arup Chakrabarti. Dr. Arup is the director of Chakrabarti Eye Center at Trivandrum and is the editor proceedings for a second term now.
Soosan has second case.
Yeah, one more case by Dr. Soosan.
Oh, yes.
Yeah.
Soosan, yes.
Yeah, if I would
very sorry.
allow Dr. Arup's case also to be shown, but
yes.
yeah, we could go in either sequence.
No, I would want Soosan's second video to be shown, please.
So this is another interesting case, which was a 12-year-old boy whom we'd done a graft for earlier, a penetrating keratoplasty, and the graft had failed. So the plan here was to do a PDEK, and he also had some cataractous changes. So I was also planning to do a cataract along with that. This is the type 1 big bubble which has been created, and since I'm doing it on a graft, on a PK graft, I need very exact sizes. So I've refined that PDEK, that type 1 big bubble with it refined rather than cut it freehand as I usually do, because I want the size to be well within the to be within the margins of the graft. Now you can see that's the graft. I've removed the epithelium to allow me better visibility. I've filled it up with viscoelastic. I'm going to do the cataract surgery first. So I've made that initial cut in the neck, and I'm going to take my forceps to complete that rhexis. So in this case I alternate between forceps and the needle, and you can see that there's that iris membrane, that membrane there. I have to go with a forceps here, as I said earlier, and try to tear that rhexis. You can see that the visibility is really compromised here, so I shift to an endoilluminator, which I hold on the outside. I've seen that if I put this endoilluminator in the anterior chamber, it sometimes creates too much of sclerotic scatter and the visibility becomes worse. The visibility through the microscope actually is better than what you see through the camera. Of course, you could put it in the posterior chamber, but here I didn't want to put it in the posterior chamber because I didn't want to enter that as of yet. Now I've removed that. I've removed some of the postosinic and all, but now you see that that was actually just a fibrotic membrane on the anterior capsule, and this is the actual rhexis. So I have to actually go around. I find that I have to go around a second time. The first thing that I removed was just a fibrotic membrane, which are these surprises that you sometimes get. I then go around and do a second time a rhexis, and I'm doing the cataract extraction. It's a very soft cataract, obviously, since it's a young child. I've removed most of it, but I've got the superior rim, which is a subincisional cataract cortex, and I'm having difficulty in removing that. Now, at this point of time, somehow I feel that I should place the IOL, and I know Chitra ma'am is going to say, why didn't you go in for the bimanual irrigation aspiration? I just didn't. I thought that I would put in the intraocular lens, and I would just aspirate it later after having the IOL as a scaffold. But then I find that I'm actually in a little bit of trouble. I tried to get it out from around the IOL. It didn't come. So then I went under the intraocular lens, and then the inevitable happens. So you can see there, if you look carefully, there's two linear a tear which is seen in the posterior capsule, and also that cortex has suddenly moved more posterior. So now at this stage, what I do is basically I do an optic capture. So I had the IOL in the bag already. I bring the optic out in front of the rhexis. I've got a good rhexis, so I've got a good support there. I've brought the optic out. I've done an optic capture, and I still have to go ahead and handle that dropped bit of lens matter. So I go via Parslenar route, do a vitrectomy, remove that part of the dropped nucleus, and then I decide to go on to the PDEK part. Now, I'm also, of course, for sake of editing, I've removed that, but we also go ahead and do a triamcinolone acetonide assisted IVTA. Now, because the iris was so dilated and fixed, I've done a pupiloplasty because you want good support for the air when you're actually doing a PDEK. I remove that chamber maintainer, that trocar cannula, and bring it into the anterior chamber. And this is the air pump assisted technique, which I find very, very beautiful, which I started after Dr. Amar had introduced the PDEK technique. I started the air pump assisted PDEK, which really makes the surgery so much more easier, and it makes it a pleasure to perform. So you can see that under air, I'm doing a decimeter rhexis. You can see all the margins of the decimus membrane. This is the EPDEK or the EDMEC technique, which also I published in JCRS. It allows you with the help of the endoilluminator to see even through very edematous corneas to identify the side of the graft. Even when you're putting it into the antechamber and visibility is poor, with just that technique, you can make out that the graft is the right way up, and you can go ahead and unfold that graft. And now, as you were doing DMEC, I don't have to make sure that it's completely perfectly centered. Instead, I can accept some amount of decentration of the graft. I inject in air. You can see it's a decentered graft, but this is the beauty of the air pump assisted PDEK. You go in through a side port and just pull it into place, and the whole graft just moves into place, which would not have been possible with a DMEC. So once I've got that, I've got the air pump going. Continuous pressurized air is being infused into the anterior chamber, and there are some folds on the in the periphery, which again I'll be removing with under the air. So these are the advantages of the air pump assisted technique. You can just unfold that very easily and very gently, get rid of those peripheral edge folds, and then we close up everything and replace some of the air with fluid so that you get an 80% fill. This is the post-operative appearance of that 12-year-old boy. He did really well with a stable intraocular lens, and you can see that the graft really cleared up beautifully. So just wanted to share this case where something unexpected happened, but you really have to think about what you can do in that situation and manage it in a way that you still try and get the best possible outcomes for the patient.
It goes without saying that was an amazing surgery. I'm going to ask Shreyash to ask his questions, but just before that, one very basic question. With this amount of lack of visibility, why couldn't you have done a PDEK first and then later done a cataract surgery? Because it sort of complicates things. You know, you had a fibrous membrane over it and a fibrous capsule, and the different things which happened could have been obviated. And there was a lot more about the cornea, so I thought Shreyash should get in and...
That's a beautiful question, ma'am. Basically, as far as possible, if I have to remove cataract also, I prefer to do it in the same sitting, because generally with the endoilluminator, you can always get a view that's good enough to finish your surgery. Now, in this case, I got stuck because instead of doing a bimanual IA, I tried to, put the lens first and then remove the cortex. But if I'd got a bimanual IA, the visibility was not the problem. Now, if I do a PDEK first and then do the cataract, I would have to space out quite a bit of time because I don't want to go immediately. And then I'm going in a maneuvering the graft, which would of course lead to some amount of endothelial cell loss. So I want to avoid that as much as possible. So if possible, I want to do everything in the same sitting so that after that, I don't have any intraocular manipulation, which can possibly lead to a decrease in the graft cell density.
Dr. Shreyas?
I just enjoyed the case, madam. It was very nice and very well done. I'm going to show something very similar. So I have absolutely no comments as well. Thank you.
What was the IOL you used?
It was actually too wonderful to question her at all.
What was the IOL that was used? The intraocular lens.
That was a sensor IOL. That's generally the IOL which I like to put. Hydrophilic IOLs can opacify when you do a DMEC or a PDEK, so those have to be avoided when you're doing an endothelial keratoplasty because of the air tamponade. So what we generally use is the sensor IOL for various reasons. One is the material of the IOL, and also second, the 3-piece structure itself lends it to a lot of being able to do a lot of maneuvers. You can easily change Intrap while you're doing surgery and you have a problem. You can easily change to a glue dial. There's so much you can do when you have a 3-piece IOL as opposed to single. Sometimes then you would have to be forced to cut and explant and then do things. All of that is avoided.
Good. So thanks a lot, Susan, for being with us today here. So we look forward to you answering all the questions, the audience participation. So we go on to Dr. Arup. Dr. Arup, as I had already started introducing, is the director of Chakrabarti Eye Center at Trivandrum and editor proceedings for the second term. He's actually a man to reckon, a household name for his surgical prowess, his teaching skills, and he's going to show us 2 videos of great educative material. On to you, Dr. Arup.
Yeah. Just give a pause. Chitra, thank you so much for your kind introduction. And I am wishing you all the best for your new term for the next couple of years. Now, the first case that I'm going to show you is a 60+ lady, angle closure glaucoma, status post YAC PI, very well controlled on medications. Intraocular pressure is in the mid-teens, and she has got significant cataract. The anterior chamber depth is more than 1.5 to 2 millimeters. So I decided, can I have the video on now? So I decided to go ahead with routine cataract surgery for her under topical anesthesia. So as as you see me making the paracentesis incisions, both superiorly as well as inferiorly, the anterior chamber is shallow. The FVR tip impinges on the anterior capsule. I was careful, so I did not have any damage to the anterior capsule. AC was shallow. The intraocular pressure was quite high. So I'm having difficulty in even injecting intracameral Zylocard, 1% Zylocard here. So I had to go ahead with the case for some reason. So I wanted my circulating nurse to start off an IV mannitol, 20% mannitol drip, about 150 cc in a fast drip, so that in 10 or 15 minutes time, the patient, the intraocular pressure comes down and the surgery becomes uneventful. And in the meantime, I thought that I will continue with the rest of the steps, like staining the anterior capsule, making the capsular Rhexis, as long as I'm able to avoid the complications, as long as I'm able to go ahead with the routine steps. And I'm just waiting, biding my time for the intraocular pressure to come down, for the anterior chamber to deepen. In fact, I was initially under the impression that if I inject OVD into the anterior chamber, perhaps I'll have sufficient anterior chamber depth, but it was not happening. And AC is still shallow. I am doing a Rhexis in a very gingerly manner, making sure that the Rhexis really doesn't run out to the periphery. Now, I normally use IV mannitol preoperatively for this kind of patients if the pressure is in the 20s, or if the anterior chamber depth is less than 1.5 to 2 millimeters. But in this case, since the pressure was in the mid-teens and the anterior chamber depth was more than 1.5 millimeter, I did not give IV mannitol to start with. When you use IV mannitol, it is important that you give it 1 hour before surgery, make the patient visit the toilet before patient comes to the theater. But anyway, so that wasn't done. And so far, so good. I somehow managed to come out with a decent capsular Rhexis, but the pressure doesn't come down. So I have to think about alternative plans. So I decided to go ahead with something that is debatable but very logical to reduce the intraocular pressure, and that is pars pana anterior vitrectomy. So I used a 23 gauge trocar cannula system to make a self-skilling sclerotomy for the vitrectomy. Now, I have trained myself. My wife is a VA surgeon, so I have watched her videos and I have assisted her, and she has assisted me for a couple of cases. So if you have not learned how to do it properly, I would suggest that you don't do this particular procedure to soften the intraocular pressure, to soften the globe, to reduce the intraocular pressure. Some people would suggest that you try to aspirate the vitreous with a thick gauge needle, but I think that is also not advisable at all, for fear of vitreous traction at the base and fear of retinal detachment. So I did the pars pana vitrectomy. I could see the vitreous cutter behind the behind the crystalline lens, behind the cataractous lens, and I titrated with the intraocular pressure. And then once I realized that intraocular pressure is okay, I stopped the surgery. I stopped the vitrectomy and continued with the next step. So the next step would be cortical cleaving hydrodissection, which anyway the pressure goes up. So I didn't want to do it before the vitrectomy was performed. So now we need to keep in our mind what exactly was the cause for the intraocular pressure going up. All the differential diagnosis should be in the back of your mind, and you should have a decision tree ready, plan A, plan B, plan C, and everything should be a knee-jerk. You should do the right thing at the right time. So is it a patient of suprachoroidal hemorrhage? Obviously no, because we have a very good red reflex, and there is no dulling of the reflex. Patient doesn't complain of any pain. If you have the minimal suspicion of a suprachoroidal hemorrhage, it is mandatory that you don't proceed with the cataract surgery, close the incision, refer the patient to the posterior segment surgeon, who will take up the patient after a couple of weeks when the suprachoroidal heme liquefies, and that is the time where you can complete the cataract surgery. So definitely it was not a patient with suprachoroidal hemorrhage. It was it aqueous misdirection? It was not aqueous misdirection because because the intraocular pressure went up before I started any irrigation maneuvers inside the eye. I did not do hydrodissection when the pressure went up, and there was no irrigation aspiration was going on, and no hydro polishing of the posterior capsule. So all those conditions have been ruled out. If it is not a capsular Rhexis block, because it was happened, the pressure went up even before the hydrodissection was performed, even before the Rhexis was performed. So far so good. I implanted an intraocular lens, a single-piece hydrophobic acrylic lens, which went into the capsular bag. Eyes sufficiently soft, and I went ahead, and the patient did well. Another option would have been for me to postpone the surgery, and take up the patient at the end of the day, at the end of the list, or on another day after giving IV mannitol. But as I mentioned earlier, for some reason, I did not want to postpone the surgery. I wanted to finish off the surgery on the same sitting itself. So making sure that the lens is well centered, and then you concluded the surgery by again having a relook at the sclerotomy site. Some amount of vitreous does come out. So as you remove the system there, so I perform a little bit of vitrectomy to remove the residual vitreous, and the congenital flap was cauterized there, and it was left sutureless, and the patient did extremely well on the first post-operative day. And so that is the end of my first case.
Actually, Dr. Kumar Arup, that was a wonderful case, literally a teaching video. But I have two questions here which I'm going to ask you together. I think you would not have had any of these problems, or maybe lesser of these problems, had you given a pre-op mannitol to this patient in the first place. Like maybe the IOP was not checked prior to the patient being shifted to the theater, although he would have been medically controlled when he saw him last in the OPD. There was that probability is there, because I'm not so sure about the limited vitrectomy being done by all and sundry, because there is a challenge, because this is a case, a small eye, a angle closure, a PI, there could be n number of situations. You could even had a fluid misdirection and whole lot of other issues besides the pre-op IOP being high in this situation. So in this vitrectomy, if you do in these kind of patients, what can happen here is that the smallness of the eye, you might find that the anatomy of the eye, the pars plana would be more anteriorly placed in some of these situations. So you might end up piercing the retinal periphery or the lens capsule, or you could have a suprachoroidal hemorrhage. So would you advise this step as a routine? Maybe you were well trained, you had your wife who taught you, but I wouldn't say that this is approach. Probably a pre-op mannitol should have been best, or you could have waited for it to the pressures to come down and or taken up the case the next day.
See, Dr. Chitra, but thank you so much for asking these questions. The proof of the pudding is in the eating. So the patient has done well, number one. And second thing is the complication management is controversial. There are different ways of managing the complication depending upon the surgeon's background, his level of training. So my dictum for angle closure glaucoma patients for being taken up for cataract surgery is pressure in the 20s and anterior chamber depth less than 1.5 millimeter. So after this case, I have been doing this kind of cases for 20 years. After this case, I have altered my threshold. And now any patient with angle closure glaucoma, I would give them IV mannitol preoperatively. But this is still not to say that intraocular pressure may not go up. So in certain situations where the intraocular pressure goes up, so this is one of the options. And you are quite right that some surgeon, in fact, I mentioned during my video presentation too, the surgeons who hasn't learned how to do a pars plana vitrectomy shouldn't do it. And you should not even do a pars plana aspiration of the fluid vitreous, because it is said, it is easier to look at the fountain of youth than look at the fluid pockets of vitreous. So that pars plana vitreous aspiration also should not be done. So ideally, what I have done in similar cases, some other cases, I have postponed the surgery, taken up at the end of the day, after giving IV mannitol, or taken up on the next day, and patient has done extremely well. But there are a lot of teaching elements, and as I mentioned, complication management is always controversial. Different experts have different ways of managing things, and I thought it will be quite beneficial for the viewers, to get exposure to this discussion.
So we shall go on to the next video now, because we're really running short of time.
Dr. Arup, what
keep
was
all the questions for
just one or two which have come, which are very quick to answer. What was the anesthesia that was used?
Topical anesthesia.
So you did the vitrectomy also under topical anesthesia.
Yeah.
And
so if I may add a point here, all my patients are under monitored anesthetic care. So midazolam is given, the anesthetist is standby. And if some patient has a problem, then I would use a plagette of Vexel or a plagette of cotton wool soaked in proparacaine, and just apply it around the area of the sclerotomy. Or sometimes we can even give just subcutaneous injection of xylocaine 2%. And this particular patient is very cooperative, so nothing else was really necessary.
I think if I can just say one small sentence is that as a phaco surgeon, I think all of us definitely need to get trained in doing a pars plana vitrectomy, especially when you're faced with situations of postcapsular rent. And as Dr. Arup said, this is also a situation which many of us face at some time, that the eye becomes hard, not just in cataract, but in different kinds of surgery. Sometimes when I do a PDEK, I get that. So this is a safe procedure actually in those situations where you can go in and do a pass. So please definitely get yourself trained for doing this.
So we shall go on to the second video of Dr. Arup, which is also going to be a learning in itself.
So please give a pause before starting the video. See, the next case that I'm going to show you is a cataract surgery in a post-vitrectomy eye. I must tell you that most of the surgeries in post-vitrectomy eyes are routine, because majority of the cases have undergone vitrectomy for macular hole surgery, for epiretinal membrane, or just simple vitreous hemorrhage. And those cases, when you see on the screen, doesn't appear to be any different from that of a routine case. But on the other hand, if you have patients who have undergone repeated vitrectomies, vitrectomy around the vitreous base, silicone oil injection, so those cases become challenging. And let me show you one such case. Can I have the video on? Please put it on. Yeah. So this again, a female patient, emulsified silicone oil in the anterior chamber. So I made 2 paracentesis tracts again under topical anesthesia. These eyes tend to be soft, so sometimes it may be important for us to firm up the globe by injecting BSS or OVD into the anterior chamber. It was not necessary here. Before performing capsular Rhexis, you perform the emulsified silicone oil BSS exchange. If the eye is soft and if you have not performed this maneuver, you are likely to end up with a large, long, clear corneal incision, and that will have problems like overlocking, corneal striae, and a lot of difficulties during intraoperative manipulations. Staining the anterior capsule with trypan blue dye is important because there may be fibrotic plaques, fibrotic patches, which you might not have seen on the slit lamp examination, like once the pupil has dilated fully on the during the surgery. See, for example, there's areas of where you see those pigmented patches, they may have fibrosis around it. So when I perform the capsular Rhexis here, I'll make sure that I go peripheral to these areas so that I don't have to really deal with these potential fibrotic patches that may come up here. Another point I would like to emphasize here is this is a second surgery. There have been silicone oil in the anterior chamber, and endothelium requests to be protected. So you need to use a good quality dispersive OVD, and I always use a soft shell technique routinely for all my cases. So this is something I wanted to emphasize. Cortical cleaving hydrodissection in this case is okay, but in certain situations where post-vitrectomy white cataract or post-vitrectomy sudden progression of the cataract, potential damage to the posterior capsule, or the surgeon has told you that there has been some touch to the posterior capsule, in those cases, I would not perform cortical cleaving hydrodissection at all. There are different ways of managing those cases. Now, the nucleus removal, whatever technique you follow, before that, these eyes tend to become very deep. So now this is a trick that you need to follow to how to avoid the reverse pupillary block. Before you engage irrigation on the foot pedal during Phaco, you just elevate the iris from the anterior lens capsule. So there is pressure gradient equalization between the anterior chamber and the posterior chamber. The anterior chamber does not become deep at all, and the rest of the surgery goes up in a very routine manner. So here, employ a technique which you are comfortable with. Your Phaco disassembly technique has to be zonule friendly. So for me, my routine surgery is I just make a little crater or a small tunnel and then start chopping. But if you're comfortable with stop and chop or divide and conquer, or whatever technique you follow, that is okay. Just ensure that you do not traumatize the zonules, because many of these cataracts come to us with a very advanced cataract, very nuclear sclerotic cataract. Zonules may be compromised, so it is very important that you take care of that. Because of the siliconal in the posterior segment, they can be siliconal upthrust. So during the last piece removal, it may be a good idea not only to step down on the Phaco parameter settings, but use visco expression for the last segment. Same thing about the epinucleus removal. We do not allow the anterior chamber to become shallow. As you see here, I always maintain the irrigation in the anterior chamber. I always prefer a bimanual irrigation aspiration for my routine cases. It slows me down, but it is definitely more. It can be done in a more controlled manner. Here again, you have to worry about the posterior capsular damage because of the silicone upthrust that may come. And this is one situation where I'd like to polish the anterior capsule, scrub the epithelial cells under the anterior capsule as much as possible. There are few other situations where I do it. For example, complicated cataracts, a patient with pseudoexfoliation, retinitis pigmentosa patients, because these patients tend to get a lot of fibrosis, capsular bag fibrosis, Rhexis phimosis, decentration of the intraocular lens. So I do spend a lot of time dealing with the anterior subcapsular cells in these situations. You see patchy opacities, usually you see fibrotic plaques, but in this case, patchy opacities, it really doesn't matter. And at the end of the surgery, of the cataract surgery, the posterior segment surgeon has removed the silicone oil from the posterior segment. So I didn't really have to alter the intraocular lens power. These eyes, again, it is important that you put a tenon island suture to the main incision, because these eyes tend to be very soft at the end of the surgery, and the self-sealing corneal valve may not really work. So there are different ways of managing post-vitrectomy eyes, and this is one such case that I just showed you.
Yes, that was a truly teaching video. There were very few questions. I had quite a few questions. You answered most of it. But one good thing, I hope all of us saw that how he dealt with iris retropulsion, which can happen in these vitrectomized eye, how he just lifted up the iris so that it gets lifted off the lens capsule. I would say that we need to be careful about the hydro, because sometimes lens touch could happen, and some of these cases are referred to us from elsewhere where we do not have a communication from the surgeon. The only other thing I wanted to ask you was, some of these cases have a PC plaque, these post-vitrectomized eyes. If the silicone oil is already still there in the eye, would you ever go about doing a PC polish, or would you like to peel off the plaque, or would you let it be like that?
Thank you, Chitra, for asking this question. For example, unlike a posterior cataract, if you have a very significant plaque at the center, and you have silicone oil in the posterior segment, and it has to be retained as per the posterior segment surgeon's advice, and it is not amenable to YAG. It is a thick fibrotic plaque. So I will do a central posterior capsular Rhexis, and I'll capture the optic through the Rhexis behind the posterior capsule, through the posterior Rhexis behind the posterior capsule. If you don't do that, in few days' time, you see the silicone oil which was there in the posterior segment comes all around, and it comes to the anterior chamber. So I perform a posterior capsular Rhexis in those cases. We capture the optic through the Rhexis, so it is now against the posterior capsule, and that prevents the silicone oil from coming forwards.
That was well answered. Shall we go on to the next video, or Rohit, I seem to keep preventing you from asking. I don't know why I've been so stickler about time.
Just
Dr.
one
Arup,
question.
just quickly,
let me have Rohit.
like what do you do with the IL power calculation?
Yeah, exactly. That was the question
oil?
everybody wants.
Yeah.
So that is a very interesting question. So there are two things. One is calculating the intraocular axial length, and then second thing is the choosing the intraocular lens power. So for all vitrectomies in my center, we do optical biometry before the cataract, even if it is a clear lens, and we keep it in our case sheet, and a copy is given to the patient for his safeguarding there. So if he goes elsewhere, so if you have silicone oil in the posterior segment, optical biometry is the way to go about it. In certain situations, optical biometry may not really help you, because if you have a thick posterior subcapsular cataract, or if you have a nuclear cataract, and these patients tend to come with this kind of cataracts, so then you may have to resort to ultrasonic biometry. All right. So if I have done an ultrasonic biometry, I'll assume a silicone oil velocity of about 980 millimeters per second, and use a factor of 0.71 and multiply it to the axial length that I have got. I mean, if I know what exactly is the centistroke of the silicone oil that has been used. Now, this is in regards IL power calculation. Now, what power am I going to use? Because silicone oil in the posterior segment acts as a negative lens. So, yes. So it has got a lower, higher viscosity than refractive index than the vitreous. So, if I'm going to remove the silicone oil at the same sitting, I would use IL power, what has been calculated. On the other hand, if I am going to retain the silicone oil for a long period of time, if it is, most of the lenses are biconvex lenses, so I'll increase the power by 6 diopters for IL power less than 24, and IL power more than 26, more than 24, I'll increase it by 8 diopters. If it is a meniscus lens, or if it's a plano-convex lens, and these are not available to us any longer, you don't have to. With the plano-convex, you have to increase the power by 3 diopters. But at the same time, you must tell the patient that after the silicone oil is removed, you are going to have a hyperopic shape. All right. So that has to be, you're going to have a myopic shape. Sorry. So that has to be.
Anytime go for piggyback IOLs?
No, I have not really gone for a piggyback IOL. I mean, I have followed this dictum, and so another option would be, if you are not very sure, you could, keep the patient aphakic, and at the time of silicone oil removal, you can calculate the intraocular lens power and implant the intraocular lens.
Fine.
Thank you very much,
This
Dr.
is a large, big topic, you know.
Yeah, yeah, very well done.
Yeah.
Both the videos were very
Very
well
nice.
done. So we
Thank
shall now go on to our next speaker, Dr. Shreyas Ramamurthy. Dr. Shreyas Ramamurthy is the younger generation, very learned, dynamic cataract, cornea, and refractive surgeon of our Eye Foundation group of hospitals. And he again is going to share with you all some wonderful, great pearls of wisdom. So on to you, Dr. Shreyas.
The outset, I'd like to thank AIOS and ARC for the opportunity. And I have my video on, please. So this is a patient who had a 70-year-old lady who had a large therapeutic graft for fungal keratitis, non-responsive to medical treatment. And over a period of time, this therapeutic graft failed. So it's somewhat similar to what Dr. Soosan had shown, but it's a slightly different technique where instead of using some lateral illumination at the limbus, I'm using a chandelier illumination. And I also use a little bit of glycerol to deturgescence, to cause some deturgescence of the stroma because it's a chronically failed graft. So there'll be a lot of stromal edema. And even though it's almost a grade 3 cataract, the visibility with the regular light is very, very poor. Now, this is the advantage of using a complete chandelier illumination where you switch off the operating microscope, where even through a very hazy cornea, as well as through a dense cataract, and the epithelium can also be removed in aiding the visibility. You can see that the entire visibility with the retroillumination, the chandelier illumination is beautiful. You can actually go ahead, do a very nice Rhexis, go ahead and do a very neat direct chop. Mind you, these are patients, it's a slightly older patient, so the cataract is also a little bit on the denser side, and you need to chop the cataract, and your visibility needs to be good. And with the chandelier illumination, although it looks like a negative image, but you get excellent illumination, you will be able to even visualize the edges of the Rhexis, do your chopping very well controlled inside the bag, and then do absolutely safe phaco emulsification. It's extremely important in these cases because you are going to combine it with an endothelial keratoplasty, and therefore having an intraocular lens in the bag is of extreme use. Because during your subsequent air bubble management, if your IOL is not stable, the bubble might go behind the lens, it might push the lens forward and make it a lot more difficult. Because this is a very hasty cornea done a few years back, I was not willing to venture doing a DMEC in this case, but I'm proceeding with a DSEC, where using a 500 micron, I've dissected out a thin lenticule and I push it in with a sheath slice. Another caveat to use is probably either to have the incision clearer or have the incision clear corneal. It's important that we don't go through the graftose junction so that there is no graftose junction dehiscence. And then subsequently, you just go ahead with your air management, fill in the globe with air. Again, in all these failed grafts, especially these large grafts, it's difficult to achieve a very tight tamponade. So ensure you're suturing all the ports, the main port, the side port, even remove the sclerotomy site, suture it completely, and then also make additional venting incisions to ensure that whatever little interface fluid is there is also removed. So essentially just wanted to highlight the use of retroillumination in doing cataracts in patients who have this kind of diffuse opacity rather than focal opacity. So in focal opacities, again, just a side illumination along the limbus is quite sufficient and you'll be able to get away with it. But in this kind of diffuse edema, illumination at the limbus doesn't give you enough visibility, and putting in a chandelier illumination makes the entire procedure very, very simple and very straightforward.
That was a wonderful video, Dr. Shreyas. I'm going to put both my questions together so that you can answer me. With this amount of compromise on the visibility of the surgery, why couldn't you have done an open sky technique in the first place for this patient? And then you've already explained why you've done a chandelier. You could get it further clear why you would do chandelier in these cases. And if you're not using any of these techniques, what are the other ways a regular surgeon could do to get about doing these cases with opacity and lack of visibility?
Doing a triple procedure as a PK ECC IOL is also possible. It's not an unreasonable option. And probably if it was an opaque graft with corneal scarring, then I would have gone on to do this. But this was only an edematous graft, a chronically edematous graft. There was no scarring in the cornea. The patient went on to have a BCVA of 6.9. So in these cases, it's always better to attempt and endothelial keratoplasty definitely gives better results. Additionally, the factor of rejection definitely in a PK, in a already previously failed graft, the risk of rejection is a lot more. It's a very large graft, already vascularized. So definitely PK, the risk of rejection will be a lot more. So doing an endothelial keratoplasty definitely helps. And the chandelier illumination, like I highlighted, definitely in these cases, a very important thing is what Dr. Soosan showed. One probably thing which she didn't highlight is she also has excellent assistants right through her surgery to beautifully hold the light, light in the correct positions when she's doing the surgery. With a chandelier, it's actually like having a third hand. You can just put it in the vitreous cavity and you're completely free, and you can just go ahead and do your cataract surgery as you would do in a normal phaco without ever having to worry about your assistant holding the light in the right position.
So, shall we go on to Shreyas' second video? Any question, Dr. Rohit?
No, I think we go on and complete, and then we'll come back.
Thank you.
So, your next video.
Yeah, can I have my next video on, please? So, the next video is actually to highlight just a very simple point, that is to take care of the ocular surface before we proceed with the cataract surgery. It is important that this is a patient with Stevens-Johnson syndrome. And in Stevens-Johnson syndrome, especially patients who've had Stevens-Johnson syndrome several years back, 20 or 30 years back, they may not really give you the history of having had an SJS episode back. And often you would find that the cornea has a little bit of punctate erosion, some vascularization, and without a careful examination, you might miss out the fact that this patient actually has very keratinized lid margin. And it is this keratinized lid margin which is going to make it extremely difficult for a patient who is subsequently going to undergo a cataract surgery. If you did not replace this with lid margin mucosa, then the subsequent cataract surgery can actually cause breakdown of the surface, rubbing of this keratinized lid margin on the surface, causing corneal melts and even perforations, making it extremely difficult. This is what had actually happened in the other eye of this same patient, where she had undergone treatment elsewhere. And only later, after she had developed all those problems, when she came here, a diagnosis of SJS was actually made. She was just diagnosed as a vascularized corneal opacity and a dry eye. But since Stevens-Johnson syndrome was missed out, this was the problem she had developed. And now with the lid mucous membrane graft, you can see the surface has stabilized. There is still a residual corneal opacity which will remain in place. But then you can go ahead and deal with the cataract in a second sitting. Once this lid margin mucosa is completely healed, can you proceed with the video, please? Yeah. Once it is completely healed, you can, after about 4 to 6 weeks, you can proceed with the cataract surgery. Again, these are patients who will have extensive symbolifera, shallow fornices, so it's difficult to insert a speculum inside. So I use these traction sutures. Then go ahead with the cataract surgery as you would do in a patient with an opacity. This is again a patient where probably a lateral illumination helps better, where you can use a lead pipe, because this intumescent cataract and the chandelier illumination will not give you any light or red reflex. But there was sufficient clear area apart from the area of opacity for me to go ahead with the cataract surgery itself. Just as you can see in the area of opacity where I'm trying to complete my Rhexis, I'm having a little bit of difficulty visualizing that particular area. So I go ahead and complete the Rhexis with a forceps, and then I do my a minimal gentle hydro, rotate the nucleus. Now in these cases, it's you can use your preferred technique of cataract, but I prefer doing a direct chop. The main reason is it's difficult to look at the depth of your trench in these cases because of a slightly hazy cornea. Whereas you can occlude in this cataract, you'll have generous, a fairly dense cataract, generous occlusion, and then go ahead with your direct chop. Ensure you have sufficient lateral separation, you've broken it down into sufficient number of pieces, and then slowly bring it out one piece by one and emulsify it. And preferably while you're emulsifying it, try to tilt the probe a little superiorly away from the area of opacity. So you're actually seeing the nucleus rotating at the tip. You know that the tip is still occluded and that you're not boring through the nucleus. And having a PCR in these kind of hazy corneas would be disastrous. So ensure you're constantly visualizing the tip while you go ahead with the surgery. And then you can go ahead and place the lens and put it in the bag, and then go ahead and suture these ports. Anytime in a compromised cornea, it's always better to put in a suture, as sometimes even though your incision might be good, they are not self-sealing. because the peripheral cornea might be a little thinner, place an air bubble, and then that's the end of the surgery. So the patient did reasonably well. Of course, continued to require scleral contact lenses, as is often the case with SJS, but went on to have a vision of about 612 with the scleral contact lens. Thank you so much.
That was a wonderful surgery, Dr. Shreyas. One simple question, and I would also want Susan to add up to it. So basically, you've dealt with the keratinized epithelium and taken care of the ocular surface with a beautiful MMG graft. Where do you get these grafts from? The lip mucosa?
Yeah, from the lip mucosa works better. Buccal mucosa is a little thicker, so I'd prefer to use a lip mucosa, and that gives you a nice thin graft. At the same time, it's well rounded, helps you form the lid margin very nicely.
Could you highlight on some other ocular surface issues which come up, we as routine cataract surgeons would miss out on it, how these need to be dealt with prior to the surgery so that the outcome of your cataract surgery is optimal?
Yeah, I mean, this is an extreme case with, Stevens-Johnson syndrome, but a very even run-of-the-mill cases where you might have patients with just MGD or patients with rheumatoid arthritis who might be on treatment, might not be really telling you that they are on treatment. It's very, very important that we look at the cornea, look for subtle signs of punctate erosion, any alteration in the tear film, look at the meibomian gland, because stabilizing the ocular surface, stabilizing the surface inflammation is extremely important. Treating the cause is extremely important before going ahead with the cataract surgery, because it can have disastrous results. Even a very subtle finding which can be missed can actually, during the cataract surgery, they may have, or the basic insult of the surgery itself will cause some focal epithelial breakdown. And these patients have difficulty in epithelialization subsequently, and gives rise to this vicious cycle where the epithelialization will not occur, and therefore the stomach becomes inflamed and there is a melt and subsequent perforation. So it's extremely important that we identify these cases early and treat them at the early.
Dr. Susan?
Yeah, I think that was a very beautifully managed case, Shreyas, both of them. One thing that I would like to add is when you come across these kind of patients, one thing to rule out is always, of course, a cicatricial pemphigoid, because those are the cases where you don't want to go in and do surgery on the conjunctiva or start off actually trigger off a process of inflammation. So that's one thing that you want to rule out. The buccal mucous membrane graft was done beautifully. I think one extra thing that I generally do is to put fibrin glue, so that you get a nice contact of the buccal mucous membrane graft on both sides of the lid, on the lid margin as well as on the inner aspect, and there's no edema or fluid accumulation under it, and you get a very nice flat apposition in the post-operative period. I think other than that, many times you often also need to put these patients on autologous serum, and of course that post-operative management becomes extremely important. You sometimes have to put an AMG and all these things. So that's about that. About the other case, the penetrating, the question that Chitra ma'am had asked about penetrating keratoplasty, I'd really like to stress on this to the message to reach as wide as possible, that endothelial keratoplasty, especially in the form of DMEC and PDEK, is the way to go. Really penetrating keratoplasty doesn't have a role if you have just edematous cornea without a scar. And many times even that scarring, if it's very subtle scarring, you still get very good vision with just the endothelial keratoplasty. A lot of the scar goes away with time, and you get very, very excellent results. So there's really no need to disturb a graft and redo a full penetrating keratoplasty and get all the problems of a neurotrophic cornea, suture-related issues, and all these things. Start off that entire cascade of cycles all over again when you have this beautiful, very quick rehabilitation that's possible for these patients. The only places where I would possibly do a penetrating keratoplasty is, one, of course, the thick stromal scar, which is not going to resolve with time. And the second one is if your first penetrating keratoplasty suturing is so bad and you've got so much of irregular astigmatism that it's too difficult to tackle, then maybe I might consider that. But generally, on the whole, you prefer to do this. With a pupiloplasty, you can get a improved vision. So, there's so many things. Please don't do a penetrating keratoplasty unless absolutely indicated.
Yeah, I agree. When I asked this question, I felt I knew what the answer was, but I thought I needed to generate discussion here. Do you have anything to add, Shreyas, before I go on to the next?
Shreyas,
no, it's just that
will you change your position of your cataract main incision depending upon the opacity?
Depending on the opacity, definitely it can be changed. In this particular case, it was just slightly inferior. So doing a superior incision would have made it a little more difficult because the opacity would have come in the way of all the chops and I would not have been able to visualize it. So making a slight supratemporal incision, at least for the majority of my phaco, I was able to avoid the opacity which is inferior. Very important to just cover that as Susan Madam was also highlighting, that to differentiate between SJS and OCP, especially in the cataractogenic age group. Of course, this patient had a typical history, drug reaction, drug reaction and everything was there. But it's the lids which are most useful in differentiating between an SJS and OCP. And this typical keratinized surface on this thing is very typical of SJS. And we have to really look for it. It's very, very easy to miss this keratinized lid margin. It's not necessary that they have to have these thick white keratin plaques, but even just the migration of the dermal epithelium over the tarsal surface of the conjunctiva, which causes repeated rubbing and that lid viper syndrome, and which causes subsequent breakdown of epithelium. So unless we really look for it, we might miss these subtle findings.
Thank you, Shreyas. That was all wonderful, the discussion, and Susan, your contribution. So we shall now go on to another awesome speaker of ours here in this panel, Dr. Haripriya Aravind. Whatever I say is going to be very inadequate, a very dynamic, highly prolific surgeon, and is a leading torch bearer for Aravind Eye Hospital. That's how I look at her. And I'm looking forward to seeing her videos, which is actually going to stun us. And the utter ease with which she does the most complex surgeries is something which I could go on and on about. So let's the audience join me in admiring you, Dr. Haripriya.
Thank you so much. That's really kind of you, Dr. Chitra. And thank you again very much for having me on this very important program. So can I see the video, please? And before I start, I'm going to be showing a case of coloboma. Can you pause the video, please? So as we are aware, the coloboma, phaco in a coloboma case could be a little more complex right from the capsular rhexis, because the capsular rhexis chance of it running away is high with the inferior zonular loss and the chance of fibrosis in the inferior aspect. Can you play the video, please? So we take good precaution. I use a soft shell technique, use a dispersive and a viscoelastic. The rhexis is complete here. You can see my rhexis was fine. However, after hydro, this is a grade 4 cataract. As I was starting phaco, I realized my rhexis was torn. So probably with the hydro, my rhexis had given away. So I'm doing phaco. I'm being very careful. A chop technique is being done. My rotation also is very gentle, but I find that the nucleus is kind of tilting. It doesn't seem stable at this stage. So I want to confirm if the nucleus is fine. So I'm just trying to move it around, and I see the equator of the nucleus, which indicates that the inferior capsular support is inadequate. So as I'm trying to prolapse it out of the bag, it tends to dislocate posteriorly. So I'm rescuing it with the help of the Sinski, which I'm using. Other hand, I have another instrument, another Sinski. So I try to sandwich this nucleus out between both these instruments into the anterior chamber. Again, this is a very hard cataract, so I would not want to extend this existing 2.2 millimeter corneal wound. So this is where our SIC skills would be useful. So I abandon the corneal incision, make a superior 7 millimeter sclera corneal tunnel. So this is, the nucleus is safe because it is in the anterior chamber. There is iris to support it. The wound can be as large as you would like it. I use a vectors here. It's a regular vectors. I just try to avoid hydration. So I try to avoid the enlargement of the capsule tear. And then the viscoelastic is used to remove the cortex. In this case, the IOL was placed in the sulcus and iris fixated. So I'm just going to show you a second case of a similar kind, but again, this is an Intumescent cataract, used a high molecular weight viscoelastic. I'm being very careful here, used a forceps, try to make the rhexis much smaller inferiorly, but as you can see, there is some fibrosis in the capsule, and it kind of runs out right there. So and again, it's very Intumescent, and I know it's going to be almost impossible to bring this back. So in this case, I don't wait to continue with phaco because I'm sure that this is going to have a high chance of lens matter dislocation. So earlier in the case, I convert, go superior, do a stable tunnel. Like I said, most 99% things would work fine, but sometimes when we do have a Rhexis tear in such a situation where there's a high chance of dislocation, it's good to convert. So I'm again using two instruments, bimanual prolapse, bringing the nucleus out into the anterior chamber. It's a soft cataract, and that is useful. So the wound would match the nucleus size. I'm placing a 3-piece PMMA IOL in the sulcus. I'm placing the IOL horizontally. So both the haptics have support. However, since the capsular support is inadequate inferiorly, I would like to fixate the haptics to the iris. Using a 10-0 ProLens suture on a long curved needle, taking a bite from the cornea, go through the iris and take a bite, including the haptic, and come out through the cornea. And then through the incision here, since it's just above the bite, I would tie the knots. So here I would, knowing the position of the haptics, I would take this bite. It's a little blind procedure, but since you know where the haptics lie, you can be almost sure to include it. And you could also confirm, after you have taken the bite, you could lift both the ends of the suture to see if the IOL tilts, which is an indication that the suture has included the haptic. Both the haptics are secured to the iris on either side. I leave the bag in place because the chance of contraction is low. It's a coloboma case. Again, we'll have to manage these patients post-op as well because there's a high chance of raised intraocular pressure, etc.
That was a lovely video, Haripriya. So the questions related to the iris fixation I would ask in your second video, because there was a lot more to it there. So here we see a beautiful case where in a lenticular coloboma you expect some zonular instability, and she deals with it SICS. And the second case, it's an intumescent cataract and she's got a Rhexis extension. She's not going to take chances and she's done an SICS again. Now the question for you here is that if you had had an intact Rhexis, first of all, maybe if you had created a Rhexis well away from the area of the coloboma and a smaller Rhexis to start with, probably that would help, would it? The second question is...
I think so, yeah.
And the second question is, if you have an intact Rhexis in these eyes with the lenticular coloboma, doesn't it make sense that we could put a CTR in these eyes, which probably would even prevent fluid misdirection through that area of zonular weakness? Your thoughts on that?
Yeah. So regarding the aspect of making the Rhexis smaller, I think that's a very valid point, especially the first case. My Rhexis was slightly larger on the inferior side. If I had made it a little smaller, that could have reduced the chance of that Rhexis extension, which happened during hydro. The second case, however, I was being very careful, but considering some of these eyes have, when you see those white, the fibrotic plaque on the anticapsule, you need to be very, very careful. Those are the cases where the chance of extension is much higher. Regarding using hooks or CTR, CTR, so either of this, I would normally delay or avoid it as much as I can, especially hooks. The only case I do not use hooks routinely in a case of lens subluxation would be a coloboma, because like I said, what seems like a normal Rhexis may give during pressure, during Phaco in a colobomatous eye. Same with the CTR as well. So I would delay the implantation of CTR. I would place it as early as it is required, but delay it as much as I can so that there is no issue with this kind of compromising the strength of the capsular Rhexis and causing an extension. Now, all this is doesn't happen in every colobomatous case, but the risk is more than having it in other cases of subluxation.
Yeah, that was
Dr. Haripriya.
Yes, Dr. Harshul.
Do you like to do pupilloplasty at the end of the surgery in iris coloboma?
I used to many years back, but now I see that patients are absolutely asymptomatic, so they don't really have, because they've been used to this all their lives. If it is a traumatic case, then I would, because then they have issue of glare and halos, etc. But I think coloboma patients have never complained, so I would spare them and more manipulation could increase chance of IOP and inflammation, so I would not do it now.
Kumar, you have a question for us?
We can't
Kumar,
hear you.
You unmute, Dr. Kumar.
Kumar.
Yeah, sorry. If you have a small Rhexis in the area of the coloboma, the opacification of the backside of the Rhexis itself will prevent the extra light from coming in. So you really don't need to do any, as rightly mentioned by Dr. Haripriya, that you don't really need to do pupilloplasty, because what I prefer is that we make a little smaller Rhexis in the area of the coloboma and don't polish off the posterior capsule, the cells from the posterior surface of the anterior capsule. Over 3 weeks, they become opaque, and that itself filters off the extra light.
I think
I would like to make one comment
Yes,
here.
Arup? Yes, sure.
But I would like to congratulate Dr. Haripriya for demonstrating a very important philosophy. That is, whatever we do has to be in the best interest of the patient, and that takes precedence over the surgeon's ego. Now, you could have really continued with phacoemulsification and landed up in more problems, but then she showed a beautiful management, and the eventual outcome of the patient, I think, would have been wonderful. So, thank you so much for conveying this take-home message for the viewers.
Thank you, sir.
So we shall go on to your second video, Haripriya.
So the second case is that of an ectopia lentis, again a spherophakic eye. So we have seen some management earlier. Here again, this is a patient who had Marfan syndrome with a microspherophakic lens. So my goal here is to, there's the option of either doing a capsular fixation, capsular placed IOL and fixing the bag to the sclera. But here I'm thinking of an iris fixation. But I want to retain the lens as long as I can, so I prevent any vitreous loss. So I do a Rhexis using a high molecular weight viscoelastic. I use the hooks. This is the regular iris hooks, which also to me works very well in most cases to support the capsular bag. So you can see the globular lens matter, which comes into the anterior chamber after hydro. Again, it's very soft. It's almost a clear lens, so it is not difficult to do a phacoemulsification here. It is almost, even if it's in the bag, you'll find that just staying there with low vacuum and very low power will be able to aspirate it out. I'm also removing the cortex. I intend to remove the capsular bag as well, but I would like to remove the lens matter completely, because even when I remove the bag, sometimes the lens matter may drop into the vitreous cavity. So I'm removing the cortex as well. The bag being supported by hooks is very, very useful here. Now the IOL is a 3-piece foldable acrylic IOL, a sensor lens being placed in the sulcus. So again, like I said, I plan to remove the capsular bag end of the case. I'm retaining the bag so long because I don't want to have any vitreous prolapse. Plus, it gives me stability to place the lens in the sulcus on table, during which time I fixate the haptic to the iris. So this is similar to the technique which I showed in the last case. I IOLIS in the sulcus. I take a bite using a 10-0 proline. The suture I'm using is from Alcon. It's a PC7. You could also use a CIF4 from Ethicon. I mean, it's a little more difficult to find these sutures, but they are useful. It's on a long curved needle. Iris fixation, I find they actually do quite well. We have had follow-up for more than 15 years with the suture fixation, and I don't have an issue of erosion, which I see with the needle sutured lenses. Once the bite is taken, it's about a 2mm bite on the iris, including the haptic. I retract the sutures through the common side port and then tie the knot, so the knot would lie on the iris surface. So the reason I don't do a complete lens removal here initially is I don't want to have any issue with posterior vitreous detachment, any issue with the vitreous traction. What you can see here is the optic being lifted and the capsular bag being removed in toto. So it's actually a weak bag, so it's not difficult to remove it. So I retain the bag till the end and then remove the bag after the haptic is fixed firmly to the iris, and then the bag is removed and viscoelastic is aspirated. So the question which comes to many people's mind is why take all the effort of retaining the bag, and you might as well just remove it completely in the initial phase. But I feel doing a complete lens removal in this case, especially in Marfan's where there's a high chance of retinal tears and retinal detachment, I feel would increase the chance of RD in these patients. So I would like to have no vitreous loss. So I would retain the bag till the very end and use the bag itself to support the lens and then fixate the IOL to the iris.
That was an amazing video, Haripriya. Actually, I have a few questions, so it's going to be like a rapid fire, so you may have to answer briefly. Very simple and basic. Can you give us a tip how you tear the Rhexis if the zonules are very weak? How would you go about it, the direction? approach?
Yeah, one is to have a good viscoelastic. It is very, very critical. Have a high molecular weight visco. You can make your nick with a needle, or you can with the forceps. Use the forceps only in these cases. And you have to have more centripetal forces. So you have to hold the flap and bring it towards the center each time. That could be useful. Alternate could also be using hooks as you're doing a Rhexis to be able to complete it if it is a really weak bag.
Okay. In this particular surgery, how do you ensure that the suture bite passes under the IO haptic each time?
So as you're inserting the needle, one is before you insert, you will have to know where your haptic lies. You could do that by retracting the iris with a Kublin's hook, checking on it. Second, when you take the bite from the corneal, let's say about 3-4 millimeters from the optic haptic junction. So your angulation would be correct. And this is a long suture needle, so this gives you enough space to actually be able to take this complete bite from the cornea to the iris under the haptic. At that position, you'll have to have the suture a little bit more vertical. As you're including the haptic, then again make it horizontal and include the iris again and back through the cornea. So it doesn't have to be through a side, but you can just take it blindly through the cornea.
Why don't you capture the optic so that the haptics get highlighted, and then it will be easier?
Absolutely, that I think works very well, and I should have, but and you can do it, but I didn't. But that will be a very useful tip to highlight the haptic.
How doesn't the bag get captured in the suture?
Abnormalities.
Removing it in the end may be a problem.
Please say that again.
Sorry, the bag may also be captured in the suture. So
it can be. Here it is placed, and even if it does, you find that it's so easy to remove it. I mean, you maybe have to go with 2 goes. So go with your McPherson's and just tag onto the Rhexis margin. Maybe in two attempts, it should not be an issue.
Only one thing, Haripriya, excellent presentation. My thought was, you said already you have a 15-year follow-up, but do you think this proline tenno has a life of some years? Because we know that proline degrades. So what's your thought on that?
So actually, I do agree it degrades, but that I feel is more for the scleral suture. I actually have a very different experience with the iris suture. I don't see that issue. I do have an issue when I do it in children. So I don't do the iris suture technique in very young patients, so like 6-7 years. But someone who's in the 20s and above, I've had no issue.
What about using nino proline instead of tenno?
A nino would work, but the suture, the long curved one doesn't come in the nino. They only make it in tenno. That's the issue.
You do not had any pupillary abnormalities or an IOP spike in this?
You would have it if your bite were too close to the pupillary rim. So you're at least giving a margin of at least 2 millimeters from the pupil edge would ensure you have a large enough pupil, and you won't have issues with the pupil distortion. Plus, you're not, as you're tying your knot, you don't want it to make it too tight. So you just want to have the knot on the iris surface. If you kind of shrink the iris, then you can have a pupillary peaking.
The other questions have been asked. Anything else, Susan? Yes?
I think it was both of the videos were really beautifully managed and shows Dr. Haripriya's skills in doing these surgeries. One thing probably different that I might have done in the, I don't do iris suture, of course. I do, it's a similar technique, supracapsular gluteal or a gluteal or double fixation with Bouquet-Cataract hooks. But basically, if you were in bag with a patient with muffins or with high chances of, retinal issues, I probably would not, however easily the bag does come out, would not like to pull it out like that. I would probably go into the vitrictor and then just remove it. It doesn't matter even if some bag is left behind at the edges beyond the pupil, because you've removed all the cortex. So that really wouldn't matter. And instead, you just do a vitrectomy and clean up the central part if you really wanted to get rid of that bag completely. That probably would have made it a bit safer.
I think her idea was not to damage the vitreous face, isn't it?
Yeah.
Keep it intact. So not do vitrectomy.
Yeah.
You could just do that with the vitrictor also. Yeah. That was my feeling. It could possibly be done in both ways. But in a patient with chances of retinal, maybe yes.
That's why when I saw her video and then I came to you, I thought you would have removed the capsule in your particular case. But you had your own good reasoning for that. So wonderful videos. So we now shall go on to our last speaker, Dr. Harshul Tak, who's also a member ARC and is the chairman scientific committee of the Rajasthan Ophthalmic Society. He's another young charmer in this group, young, dynamic, and has a superb skill of making the most complex of complexity appear so easy and so trivial that you start wondering when you watch his surgeries that what question would you ask? The question would be quite stupid if you ask that. So let's watch him as our grand finale for this evening webinar. On to you, Dr. Harshul.
Thank you so much, ma'am, for your kind introduction. So today, the first case which I'm going to show is a case of a posterior polar cataract. We all know that the posterior polar cataract is a nightmare for any phaco surgeon because there are high chances of posterior capsule rupture. So this is a typical onion ring shaped true posterior polar cataract where posterior capsule is very weak or it may be defective in that area. So can you start the video please? So the whole idea in the posterior polar cataract surgery is to try to delay the opening of the posterior capsule as much as possible. So all our maneuvers are targeted towards that. So I can't emphasize more on the sizing of the capsular Rhexis that it should not be more than 5.25 millimeters because if there is a uncontrolled PCR, we need to put a 3-piece IOL, and for that we need to do optic capture. So now after doing slight hydrodelineation, it's a grade 2, grade 3 cataract. So I go ahead and give the first chop and see I'm not separating them more laterally so that there is no traction or no pressure on the posterior capsule. So that I take out the first piece from the capsular bag and tilt the phaco probe on the other side and take out the second piece. So we try to avoid the rotational forces as much as possible so that the posterior capsule doesn't open up at this stage. And this is the last nuclear piece which you take out. And now I go to loosen up the whole epinuclear material all around the 360 degree. And this is the central plaque which you can see is the area which is attached firmly to the posterior capsule and it should be taken up in the last. So I'm just loosening up all the epinucleus all around. And once I loosen up the epinucleus, then I try to take off this epinucleus. So these are the last pieces. And now see, still the central posterior polar opacity is there. And now this whole area is flipped off. And as this is a true posterior polar cataract, as this is flipped off, the posterior capsule opens up. And now at this stage, remember to not withdraw all the instruments from the eye suddenly. Just go ahead and put viscoelastic, stain the vitreous with the triamcinolone, and do bimanual anterior vitrectomy to clear off all the vitreous from the anterior chamber. Without doing this complete anterior vitrectomy, you cannot go and take off this cortical matter. So remember, if you have a PCR and vitreous in anterior chamber, is not the end of the game. Your game has just begun. And this will be very crucial for the post-operative follow-up of this case. So again, I'm maintaining the anterior chamber at every stage. After doing complete anterior vitrectomy, you can easily strip off this cortical matter from all around. So I go ahead from one side, take off the cortical matter. And once go ahead and put viscoelastic before changing my hands. So I take off the aspiration cannula, put viscoelastic again, and change my hands. And this you can only do if you have done complete anterior vitrectomy from the anterior chamber. That's why it's very important that you stain the vitreous with triamcinolone. And so this is the last pieces of cortical matter, and you can see a vertical defect in the posterior capsule. Again, you maintain the anterior chamber, and this is a 3-piece IOL. Remember that your leading haptic, it goes horizontally behind the iris, and you just turn it in the anti-clockwise direction, and then dial the trailing haptic in the sulcus. And now here the importance of the sizing of the anterior capsular Rhexis comes into play. To capture, you need Rhexis not more than 5.25 millimeter in size. So I go ahead, use a Q-Glance hook, put OVD, and tilt the optic on both the sides to capture it behind the anterior capsular Rhexis margin, and check on both the sides that we have captured nicely. Again, do limited anterior vitrectomy to clear off whatever vitreous is there. And once you are done with this, I go ahead and put Miocol. And this all surgery is under topical anesthesia, you can make out. And then again, I go and hydrostitch all my incisions. and this finishes the case. Now let's see the post-operative photograph of the patient, that how did this patient behave. Now see, this is the IOL, 3-piece IOL, which is locked nicely because of the optic capture, so that it gives a long-term stability to the IOL. So with this, I'll end my first video. Thank you very much, ma'am.
That was a wonderful teaching video. I think we got to know all that we need to do in polar cataract. But something now that we are investigating a lot now, do you think you would like to add an anterior segment OCT evaluation pre-op in these polar cataract? This was a very obvious cataract where you know you're going to have a PCR. But sometimes in some of these cases, you could actually avoid planning a toric IOL in those cases when that anterior segment OCT tells us that there is a possibility of posterior capsular dehiscence. So, what do you think
of
about
course,
that?
we do anterior segment OCT, ma'am, and it definitely helps you. So basically, but still your counseling to the patient, it never changes. Even if we do anterior segment OCT, we always take it that if it's a true posterior polar cataract, there are high chances that it will open up. So we need to be careful. And moreover, toric IOLs, if it opens up like this, in this fashion, where we can't convert the posterior capsular, it's your posterior capsular axis, we can't put a toric IOL because there is no toric which is available in 3-piece. So of course, we need to explain to the patient, I have backup of the lenses available in these cases.
Yes, Dr. Arup?
Yeah. So Harshul, I think I have to congratulate you for a case that was very well done. A little comment on a small comment on the vitrectomy technique.
Yeah, even I wanted to ask that.
Yeah. So now after doing the vitrectomy, which was very well done, I would not switch over to the irrigation aspiration handpiece. I use the same vitrector, and the same vitrector now will be using an irrigation aspiration cut mode, so that you remove the. Otherwise, it takes a lot of time, and you really have to go through the incision and come out several times. Very well done surgery.
One more point I wanted to say, Harshul, very well managed. Only two things is, when your vitrectomy was over, I saw a rectangular PC tear. And when you showed off post-op images, it was a linear tear going almost beyond the CCC and beyond. I was just wondering, could you have placed a single piece IOL in the bag, horizontal to that of the tear, instead of putting a 3-piece in the sulcus, which is of course the right thing to do. But could we have gone ahead and done a single piece IOL in the bag? Because I thought your
with such a long linear tear, ideally it should not be. If you can see the edges.
I also somehow feel that to place a single piece in the bag with the posterior capsule open, you should convert it into a PCC if you can. And then placing a single piece in the bag makes more relevant sense. Then the way he did it was the best.
Lovely.
Transilon which you used, I really want to ask all of you. I would do a vitrectomy first, then I would inject Transilon S29 to know whether there's any residual vitreous, and then I would go ahead and complete that cutting. Would you all of you inject Transilon right in the beginning itself?
Beginning.
At the beginning, yeah.
Beginning, yeah. There are some recent reports where you have a single piece IOL in the bag with a PCR, and then you actually do a optic capture so that the optic is brought out of the the Rhexis, and the thick haptics still lie within the thing. Now, I've never done this. And I'm not sure how good it is.
There has to be an angulation of the haptic to the optic to do that. That optic capture in a single piece, even I've read that article, 2-3 of them, but it doesn't.
There's reverse optic capture you're talking about,
Basically, it's of a single piece acrylic IOL.
But there are chances that.
the panel's opinion, because I've not done this, and I'd like to know their opinion as to how good this is even to prevent UGH also, because you still do have a thick optic which is lying, so and you might have.
Let me address this issue. See, now supposing if this is a primary surgery where I have to implant the lens, I would go do what Harshul had done. But if I was dealing with a case where the Rhexis is intact, there's a huge PC rent, and there's already a single piece hydrophobic acrylic lens in the bag which is getting decentered, which has got dislocated. So that particular case, instead of trying to bring it out and cut it and explant it, I would relocate it in the bag, the haptics, and bring the optic in the reverse optic capture and put it in front of the capsule. See, it is a vitrectomous dye. So I don't think there is the issue of, though that they have a square edge optics and all that, very very sharp angulation and all that, but still it will not rub against the iris pigment epithelium as much as it would if it was a non-vitrectomist dye.
You mean because the whole thing falls backwards a bit?
Yeah, yeah. Said the vitreous segment, the posterior segment has been decompressed to a certain extent, so the bag will be located a little posteriorly. But I never do as a primary procedure. No.
The Rhexis size also, I think, matters. If you have a larger Rhexis, then this doesn't stay. So it tends to, you can't capture. So you have to have the little smaller Rhexis, then you will be able to capture.
Shall we go on to your last video, Harshul?
Yes, ma'am. Can I have my video, please? Okay, so can you just pause it? Yeah. So this is a video which is a case which has intumescent cataract, as you can make out here. So there are multiple challenges in this case, and let's see the video and I'll narrate it. Can we start the video, please? Yeah. So this is again under topical anesthesia, and we all know that the capsular Rhexis creation is the biggest challenge in these intumescent cataract because of the raised intracapsular pressure, because of the liquefied cortical matter, as you can make out. So I go ahead, stain the anterior capsule, make my standard 1.8 millimeter incision. And this is my sequential two-stage capsular Rhexis. See, as soon as I puncture the Rhexis, I make a curvilinear cut there, and the liquid fluid comes out. I go ahead of this margin of the tear, flatten it, and with using the microcapsular Rhexis forceps, I try to make a very small Rhexis in the center, because this is the area which is safe zone where you can play around. So once I make this small Rhexis, I go ahead with 27 gauge cannula, and you see the whole liquefied material is being sucked in this 27 gauge cannula. I go from side port incision, decompress, go from another side port incision and decompress. So this is the way, once you're decompressed the capsular bag, you can easily create the capsular Rhexis of desired size. Go ahead, give one snip with the micro scissors, and again with the microcapsular Rhexis forceps. See, I'm able to achieve a capsular Rhexis which is adequate size, and its cataract is a grade 4 kind of cataract. So for nucleotomy, I use the technique which I call drill and chop technique. So once I finish the capsular Rhexis, I start drilling in the center so that it weakens the central endonuclear core, and I get a good grip for chopping. So once I drill in the center, then this is 1.8 millimeter standard Phaco tip of my Phaco machine, and I go deeper down in the center and hold it after drilling in the center and chop it, pulling it towards me. So see, it gives a full thickness through and through crack. So once you achieve this crack, again go ahead and hold the nucleus. So the chopping is the key here. So you chop this nucleus into smaller pieces, taking care that there is no posterior cortical support there. Whole posterior capsule is open. So piece by piece, you take off the entire nucleus. So this is you think this is the end of the surgery? No. So there is very little cortical matter which is there, which I'm taking out from one side. And I go ahead and change my hands. And now see what happens. See the replay. So I held this capsular Rhexis margin, and the zonules, they got torn from there. So remember that never come out suddenly. I go ahead and put viscoelastic, inflate the capsular bag, and now I'm going to use the CTR ring from the side port incision and go in the area where the zonules are got torn in that area. And once you put the CTR ring, you know that yes, you've achieved the stability of the capsular bag. And then I go ahead and put the IOL in the capsular bag. I'm keeping the haptic in the area where but see the Rhexis is overlapping much in this area. So I go ahead, give a cut there and enlarge the Rhexis to the adequate size. And this smaller size was only responsible for, pulling up away the capsular bag and fornix from that area. So the smaller capsular Rhexis size always create a problem. And this is the hydro stitch incisions. This is my hydro stitch cannula. You can see it's curved. It's very easy to use. You can attack all the side port incision from easily, and that finishes the case.
Harshul, that was again a wonderful video.
Thank you.
But just a little doubt I have. I feel that if it's an intumescent cataract, can you hear me?
Yeah, I can hear you, ma'am.
Intumescent cataract with fluid cortex, a small opening as you made would be enough to decompress the bag and remove all the fluid. But in these kind of cataracts, a little moderate dense, there could be more fluid hydrated cortex than that fluid. So in these cases, maybe a little larger would have allowed you to go get better approach in all directions and remove that kind of hydrated cortex to decompress the bag, because your nucleus was fairly hard too. So it just
no, ma'am. Actually, this is the technique which I've been using for years now, and this is my standard technique for all intumescent cataract, and it works wonders. If you try to make a bigger opening, there are chances, there may be radial extension of the anterior capsule tear. But the central area is the safest area where you can play. And as soon as you go in mid-periphery, there are liquefied cortical matter and spokes which you can see. It tends up like this. So even if you use a high molecular weight OVD, the central area is the safest, what I feel, and it works well in my hands.
No,
and you saw the capsular Rhexis creation is not an issue. I just want to show this case because inadvertently you can catch up the zonules. But the thing is that you should stop there and don't come out suddenly, and don't you don't do things which will extend it further. And try to first reinforce that area, the zonular area where the capsular fornix is coming up, and then you put an IOL and secure it in place.
So, can I say something here?
Yeah, all of you.
Yeah,
can.
Dr. Kumar.
So, excellent presentation, and what I feel is perfectly managed Rhexis. I think what technique you're doing is perfect. The only thing is during IA, what you might have held by mistake is the back surface of the anterior capsule.
Yeah, that's what. Yes.
That caused your zonular dialysis.
Yes.
But the take-home message for everybody here is what you've done perfectly is always start inserting the endocapsular ring opposite to the area of the zonular dialysis. So never start in the area of the zonular dialysis, because when your islets end, and if you're in the same direction of the zonular dialysis, your two islets on the endocapsular ring will be in the area of the zonular dialysis. So what you did was perfect. You started in the area opposite to the zonular dialysis. So when the whole endocapsular ring is in the bag, the two islets are opposite to the zonular dialysis, which needs the maximum support. So that's one thing that everybody has to remember, how to put an endocapsular ring inside.
I may, if possible, beg to differ slightly here. I think when you have a zonular dialysis, one of the things is to go towards the zonular dialysis so that you're not, the leading edge of the dialysis is not actually pulling the entire bag there. Of course, you can do what Dr. Kumar said also if your dialysis is not too great. If it's not a very big dialysis, and then you can do this. But otherwise, if it is a big dialysis, you wouldn't want to pull on the other side with this.
I agree with Susan, yeah. But I think what Kumar meant was you start inserting the thing from the opposite paracentesis, make a paracentesis opposite side.
Yeah, I think his point is very valid that you don't want the islet to end in that point of that piece of dialysis. You want the stress to be actually redistributed well with the ring rather than with the islets, and the islets as such will not contribute to the redistribution of the stress. So that's a very valid point, sir. The other thing I was thinking of saying, just a point in adding, is that when you have the small wisps of cortex, which is generally what you get in these kind of cataracts, maybe one thing that I use is just use CapVac. Just use the CapVac to go and grab that this thing. Sometimes it works, sometimes it doesn't, because the wisps may not block the entire this thing. But you can just kind of do CapVac and do that, and a lot of it just gets freed up, and you don't get that accidental pull with maybe excess vacuum used.
Dr. Rohit, I'm sure you would have a few questions.
So one or two questions for Harshul. Harshul, was that when you're increasing that nick,
Could
so
you be louder?
Yes.
when you're making that nick to extend the rhexis, would it be a radial or an angulated nick that you'll make?
See, it depends on the location from where you need to enlarge the rhexis. So ideally, we always try to give a tangential cut so that it doesn't work. But in this case, it was I think whoever has asked the question, he has rightly noticed this.
Yeah.
Because the area where I wanted to enlarge the rhexis, I could only make a radial cut there. But if you make a radial cut, you see, it's very crucial the way you first catch the rhexis. So that is very important. If it's a tangential cut, you can very easily enlarge the rhexis. But if you make a straight cut like this, if you make a radial cut, it's very difficult to initiate the tear. There are chances you may go in periphery. So you should be very careful that you keep on seeing the leading edge and your pull should be towards the center.
Only one more thought here was that anyway you put an endocapsular ring. So these capsular bags are not going to phymose.
Yeah.
Even if you're not expecting, nothing would have.
Still I love enlarging the rhexis, to have a
gymnastics.
Perfect sizing at the end, because we are competing with femtocataract surgeons, no?
Dr. Kumar, there was a question for you that when you have an anterior capsular tear, where would you want your lens haptics to be placed? So usually we would want it horizontal, but if it's say a tear in that direction,
so your lens has to be perpendicular to the tear.
Right.
As simple as it.
Just one more point on that same note is that we had the question of can we place toric lenses. I think it's absolutely fine if the axis were away from the area of the tear. But if your axis were to be in the area where you had the rhexis tear, you may have issue in placing it on axis. That's something which you'll have to decide before you choose on a toric or a monofocal lens.
Any more questions, Dr. Rohit, before we conclude?
Dr. Arup, there was a question on the risk of RD in a case in which you have done vitrectomy prior to your cataract surgery. So in the long term, have you noticed any retinal complications?
No, I think that is a very, very valid question. So because it is an additional manipulation, I've gone through the past and I've done vitrectomy. So these case patients are definitely are more prone to develop post-op complications involving the posterior segment. But we have been following up the patient, and so far so good. But I would definitely not advocate in this context pars plana aspiration of the fluid vitreous. That is more dangerous than what has been done.
I think also post-operatively you should get a retinal evaluation done.
Of course, of course.
That's an important point when you do these maneuvers.
Can I add one point? Yeah.
A question to you only, Dr. Harshul. Would you do an indirect in a posterior polar cataract routinely before you put in the lens? So that's one of the questions.
Yeah, indirect is routinely done for all the cases. It's a routine practice, not only for posterior polar. Yeah. I wanted to add one comment on Dr. Arup's case, the first case which had intraoperative hard eye, sir. So
yeah, please go ahead.
The first case which had the intraoperative hard eye before you started the surgery.
Yes.
Yeah.
Go ahead.
Go ahead.
Yeah. So I noticed in one case which was intumescent cataract, when we dilate the patient 3-4 hours before, so when that patient came on table, I touched the eye, the pressure was very high, the same as you showed that case. And cornea was also edematous. So there was an acute angle closure attack in that case. We measured the pressure, they were very high, 50s around. And I had to postpone that case, put mannitol, and after one day we took the case. And what we changed after that is we never dilate the intumescent cataracts before 3 or 4 hours before the surgery. I most likely try to use the Phenokin Plus, which is there, or just half an hour or 45 minutes before the surgery. That's what I have felt in these kind of cases. I think the same thing happened with your case. It was a
it was not that. It was an angle closure glaucoma post YAC PI. Pressure was very well controlled over the last 3-4 years. And intumescent cataract, you are right. If the AC is very shallow.
But when we
if the AC is very shallow, I
Before
would not.
starting surgery, when we check the.
If the AC is very shallow, of course, we'll not dilate the eye, and we'll dilate the patient only 1 hour before surgery when the patient walks into the operation theater. So that's a very valid point. I never dilate my really hyperintumescent cataracts where there's hardly any anterior chamber. So those are done only 1 hour before surgery, and then we take the patient up for surgery.
Another thing is we do all the surgeries in topical anesthesia. The moment you touch the patient's eye with the forceps, the patients which have the high IOP and like this, they will start complaining of pain, lot of pain. So that gave me the clue in that case that why the cornea is edematous and why is complaining of so much pain instead of giving paracaine. So that's another clue which I think the surgeon.
See, the pain in your case, pain was because of acute elevation of intraocular pressure. But in my case, absence of pain actually suggested to me that I'm not dealing with a case of suprachoroidal hemorrhage. Of course, I had a very good red reflex, but there are certain cases. I have cases where when I had the suprachoroidal hemorrhage in a very dense cataract, there's no red reflex. Those patients complain of pain. So that is an important clue. Absence of presence of pain when the eye becomes hard.
Dr. Rohit, should we conclude?
I think so. I think it has been a fabulous session with superb presentations and excellent discussion. All presenters were superb, and there were a lot of questions, but many of them got answered, and many of them I hope will be looking forward to our next series of webinars and get answers there, I guess. Wonderful, and thank you, Dr. Chitra. It was a wonderful, organized.
Thank you very much.
Actually, I want to thank all of you. My very special thanks to Dr. Kumar, Dr. Arup, Dr. Shreyas, Dr. Haripriya, Dr. Harshul, Soosan, and my very, very special thanks to my moderator, Dr. Rohit Saxena, who did a great job. I cannot but not thank our terrific Ento team, Dr. Nikhil Masukar and Dr. Raman Marke, who was so much with us in the last couple of days, and the entire efficient team who worked tirelessly. Definitely thank you very much, Dr. Sai and Mr. Krishna. And thanks all of you for being patient and being with us throughout the session. Let's all be safe, happy, secure. I would love it if you all come up with some suggestions and thoughts for our future AC webinars in the near future. And thank you very much for being with us today.